Hello, everyone. My name is Anna Rozanowski, and I'm the Chief Operating Officer of CDIQ Consulting. We are thrilled to welcome you to our free CCDS exam prep webinar series today. It's wonderful to see so many of you joining us this evening, and we're excited to have this opportunity to connect with you. At CDIQ Consulting, our mission is clear. We're passionate about empowering healthcare through education. We believe that equipping professionals like you with the knowledge and tools you need is key to driving meaningful change in your industry. Before we dig into tonight's session, I'd like to share a little bit about myself. I am CDIQ Consulting's operational alchemist and data-driven navigator, using metrics to guide business growth. I'm a passionate client champion, ensuring the well-being of our organization and our customers alike. I'm a seasoned business development director, along with having international experience as a procurement professional, working both for the U.S. Army and the Air Force. Now, I'm honored to introduce Dr. Tarman Aziz, who is an MD with a CCDS and also an exceptional leader in the CDI field. Dr. Aziz, please take it away. Thank you.
Thank you so much, Anna. I appreciate that introduction, and welcome to everybody on the call. I don't think we've had quite as many people at our webinars as this in some time, so we're really thrilled to see this type of attendance and appreciate you coming. We do have some interesting introductory comments today to talk about regarding the CCDS exam and how you may endeavor to prepare for that exam. But to begin with, just a brief something about myself. I'm an internal medicine physician by training. I trained at both the State University of New York in Brooklyn, as well as at the University of Oklahoma Health Sciences Center in Tulsa, Oklahoma. And I have been involved with CDI work and revenue cycle work since 2012 or so. And I particularly was eager to merge a lot of my prior education companies back in April of last year into CDIQ Consulting, where oh yes, sorry, I do see a chat box comment. If you could all please mute your microphones until such time that you would want to share something that will help us with the background noise. Thank you. Thank you, Katie, I think, for the reminder there. In any case, the idea here with our program, there are so many wonderful resources available in the community for preparing for the CCDS exam, and some of them are mandates that we'll talk about in a moment to be able to pass that test. What we bring to the industry that's a little different than others is a tailored and customized curriculum that really puts you through your paces on the areas of your greatest learning needs, your greatest opportunities for improvement. And so that's something that we're going to be getting into shortly. I've had the insights as a documentation champion and as a quality auditor in CDI and having reviewed charts myself for years in CDI operations to really have a good window of insight into preparing for that test. I've taken the CCDS exam successfully, and I'm familiar with its current content as well. So let me talk a little bit more to that point by way of these slides. Where would you go to find the topics that are actually covered on the CCDS exam? The topics themselves are nicely covered by the ACTIS publication, Association for Clinical Documentation and Integrity Specialists, or ACTIS publication, here that we see the examinee candidate handbook. This is a particularly useful document for anybody who wishes to consider taking the CCDS exam and knowing what is the actual body of knowledge that you're likely to be tested upon. There's both guidance for the CCDS and for the CCDS outpatient examination as well in the same handbook. And in this particular course that we're currently offering, it's the CCDS, not the CCDS-O. That's the exam that you're prepared for. We do have a CCDS-O exam prep course coming. It will likely not be released until second quarter of this year. So if you are interested in that certification, please feel free to reach out to us at a later time. So that's where you can find out course outline, topic coverage, and things like that. What about to get involved with the proper concept reviews and the basic review questions that kind of reflect what you can expect on the test. Another wonderful product here. So these are both must-haves. You must have the published exam candidates handbook, or you won't know the playing field that you're entering. And you must have the CCDS exam study guide, ideally this one, the fifth edition, which is particularly useful in terms of its latest and greatest updates, great summary reviews. You're also afforded a 100 question exam that's online and is very useful for you to understand the basic types of things that you'll be tested upon. But what if you think maybe you need more than that for whatever reason, or what if you did not pass the first time, even when you use some of those resources? This is where our program may be of some interest to you. The CCDS exam preparation course that we offer is a 30-hour course uh, with 15 two-hour classes for 30 hours in total that covers a whole spectrum of different components of the CCDS exam, but maybe from a perspective you haven't looked at before, a more integrative perspective that tests your knowledge of basic HIM operations as they relate to CDI, your understanding of medicine, medical diagnostics, and the way providers sometimes misrepresent what they're treating very well in terms of less than ideal assessment documentation, and really learning to decipher how to then review the chart carefully and write the appropriate queries. Having done that for a few years, you should be able to answer questions about suboptimal provider documentation. So that's a whole portion that we address. And we also look at a host of other things like program metrics. Increasingly, there are more program metric questions. So when I get into an overview of the 30 hours, we'll have a chance to talk more about what exactly constitutes the 30 hours in our live, online, dynamic, interactive course. It's delivered over a learning platform, an online learning platform called Graphy, if you're familiar with the name. And it's like any other online learning management system for a enrollee. You have a login, you have a password, you have access to course materials that you can access for up to a year after your course ends. You have recordings of all of our classes and a question and answer bank at the end of each week that allows you to see why the right answers were right and why the wrong answers were wrong for each of the items that were assigned and discussed. So it's a pretty comprehensive course that we offer. It includes core concept study guide type sheets for each of the 15 classes that can keep you on track with that which you maybe don't know so well. Even if you've done CDI for 3 or 4 years, maybe you didn't review certain charts as much as others, and you may need some refreshers here and there on certain underlying diagnoses, pathophysiology, treatment, and things that help you recognize query opportunities. So what is your best CCDS exam study resource? That's what we really are interested in. And how about that customized curriculum? Why not study for the CCDS exam from the perspective of learning and applying concepts that you require for success? Because for some reason, no fault of your own or anyone that you work with, those concepts didn't make it to your knowledge base when you were diligently reviewing 25, 30 charts a day, trying to get your chart reconciliation and trying to go to all the other required activities in your day. You just missed a few coding clinics, you missed a few applications of the code set. It's not uncommon, but why should you review every single thing if there are areas that you know quite well? So this is the methodological approach we take to our, uh, particularly to this course, CCDS exam preparation. There's no way better to illustrate what we do in those classes than to share a couple of questions and give you in the audience a chance to use the chat box or to go ahead and turn your microphone on and give us your perspective on what you think the answers might be. But I'm going to be quiet here for about a minute and let everybody here read through the question, and we'll see if we have any volunteers to comment by chat or even come on the microphone and share their thoughts with us. I'm excited to see a lot of correct answers making it into the chat box. So anyone who's correctly picked choice A, which is indeed the answer to this question, might be brave enough to tell us why you liked A, and quite specifically why you did not care for choices B, C, and D. I see Abby uh, has a hand
Hello.
up. Hello, Abby.
Yes. Hi.
Hi.
So I picked option A for two reasons because I've had some classes with you and I feel so confident now. I feel like I can almost answer any question.
Ah, okay. Thank you,
But
Abby.
also because I know for a fact, when you have respiratory failure, there has to be some sort of labored breathing. There has to be signs that this person is having trouble breathing. And so option A is the only one that has that part that says, this person is struggling to breathe. And then there's some evidence of hypoxia. And that's why I picked option A. The other options are good. They are things that would usually happen. But for to be certain in its respiratory failure, you have to have labored breathing and hypoxia.
Very nicely summarized. Thank you very much. I see some other great responses here. Let's see. Let me go back up. Uh, let's see. B, C, and D lack symptoms. Very nice. Very nice. But when we define a diagnosis, we're not particularly interested in the clinical indicators just yet. The clinical indicators and the risk factors and the treatments are there to validate a given diagnosis, but the definition of a diagnosis usually has a couple of two, three core elements that need to be met as benchmarks of the illness. And as Abby nicely summarized, there should be some sign of an increased respiratory effort, as well as some sign of hypoxia. It could also be hypercapnia. It could also be hypoxia, hypercapnia together. But in this question, we were asked about acute hypoxemic respiratory failure in the example, so fair enough that it says hypoxia in the correct answer choice. Um, I see another good comment. Symptoms and diagnostic criteria needed for diagnosis of acute hypoxemic respiratory failure. Absolutely. You need all of them, the symptoms, the signs, the indicators, all of the validating elements in order to uh, pick up that diagnosis properly and to make sure it will withstand audit and be truly considered valid and treated for the stay. But in the end, it's also the audit proofing of the diagnosis that many people like to think about with some of these other elements. So I see also, was it Katie had your hand up? Please feel free to jump in as well with your microphone, unless you tapped your hand up by mistake. You're welcome to come on, Katie Kaufman. If not, no worries. Um, so, all right. Why do you think many people choose B, PF ratios and O2 sats? Anyone have an opinion on why that's the most commonly picked wrong answer here? No, sorry, Katie, we couldn't hear you. Um, feel free to try again. If you turn your mic on, maybe I can turn it on for you. Let me take a look. You can feel free to text your idea to us then. In that case, no worries. Anyone want to hazard a guess why choice B is the most commonly picked wrong answer for this? Insurance approvals require the diagnostic criteria to support it. True. So because you're thinking from a perspective of validating clinical indicators, do these match acute hypoxemic respiratory failure? Yeah, I mean, for the most part, these match well. Less than 300 PF ratio, O2 sats below 90. It doesn't say on room air. I would have liked it to have said on-room air to be excited about choice B. What about mechanical ventilation? Why do so many people also pick choice C when they see this, if they're inexperienced with uh, this concept? Why the wrong answers are wrong also has to be explicitly discussed in all of these classes, because you might get something right for the wrong reason, like you eliminated or you guessed well. Sharon says it shows failure, right? The ventilation itself can be evidence of failure. Are there other circumstances when a patient may be ventilated, though, that doesn't have to do with actual clinically valid acute respiratory failure? When else might you intubate a patient? Very good, Robin, for airway protection. That's a great example. Or if you think they may soon be going into respiratory failure, or if they're going into a surgery, very good. So there's many times we may place an endotracheal tube into a patient, and we may then think, because that we see that so commonly associated with um, acute respiratory failure, that it's a mandate to be there. And certainly it is not. Many do have it, but you can have acute respiratory failure on 5 liters or on some high flow nasal cannula if you have the rest of the picture clinically valid, right? And it starts with, do you see increased work of breathing? Do you see objective evidence of hypoxia? If you've reviewed enough charts, then we've all seen the acute hypoxemic respiratory failure in the assessment and plan. And yet in the physical exam portion of the note, the respiratory findings are clear to auscultation ×2, normal inspiratory effort, no use of accessory muscles. So which is it? That's certainly a perspective to consider. Edith adds in very nicely here. D is popular reason among payers for denials, although it's not based on literature. Very good. In fact, some CDI programs have adapted their acute respiratory failure definition at the local facility level to mandate the patient has to be on at least 5 liters per minute. But that actually doesn't work for the actual definition for the official coding guidelines and the clinical definition as well. So that's a good adaptation when programs do that, I suppose. But now you're practicing CDI less as a purist and more as someone focused just on denials management. But these are all important ideas to share about a question like this. You can see that any given question, even if the question may be entirely apparent what the answer is, but by discussing all 4 choices, why one is correct, why the other 3 are not correct, we end up covering a little bit more than just the question itself. So other thoughts? Anyone else want to add something to the chat? Seems to be the easiest way. Feel free to grab the mic, though, if you wanted to pass a comment along as well. You're welcome to do so. And I will get a transcript of all of these chat commentaries, including the ones that I didn't have a chance to acknowledge so far. Some of them at the top, I'll have to scroll back at the end. We do have a Q&A period at the end where you can all ask your questions of us as well. So how are you going to go about doing this on test day? What is the test? Let's say you weren't so well versed in the definition of acute respiratory failure, and it all kind of blended together. One's a signs and symptoms validation piece. One is the actual definition. You might want to start looking at questions like this, where you start focusing on the key words. So a newer CDI specialist feels apprehensive about sending a clinical validation query for whatever reason, whether the provider's angry or not. We may just have apprehension for other reasons, that's fine. But the CDI manager says, teach them about the definition of acute respiratory failure. So we know that the strict definition of the disease does not rely on a specific, it's not that every single time the patient has a PF ratio of less than exactly 300, there may be extenuating circumstances. What if the patient's on home oxygen for chronic respiratory failure. Now the PF ratio is decidedly not that helpful. And we've already mentioned why some of the others don't make it. But if you notice also, if a patient happened to be found to have a PF of less than 300 or a SAT less than 90 on room air, if they happen to be on a vent, if they happen to need more than 5 liters, um, there's no issue with clinical validation. So it's very much a valid diagnosis. So if you were to not mention increased work of breathing and the objective evidence, now you'd need to uh, send that clinical validation query because it's the most core and fundamental part of the definition. So let's move on. I want to leave plenty of time for your other questions. Um, I'll again remain silent while you consider this next question. Thank you for the conversation around that first one. Okay, I'm starting to see the answers. Two of you have responded, fast readers, fast processors. As you all think about this question further, sometimes a question is pretty clear as to what you need to do to answer it. Other times, if you're not as familiar with the concepts in the question, it may help you to rephrase the question in some way or to try and summarize the point that's being made about the question. So I see a number of people have picked the correct answer. Any of you monitoring the chat box can now see that choice B is correct. Yes, great job. Those of you that knew it was choice B as well, good job to you, even if you didn't share with us that was your answer. And again, I would seek any of you welcome to come on the mic. You don't have to stay muted if you have something useful to share with us. Come onto the mic and let us know what you're thinking about choice B and why you like it. And most importantly, why do you not like the others? Very good. I see Catherine says simple pneumonia versus complex pneumonia, DRG. That's the right track, Catherine. That's the reason for the answer being choice B. Okay, you're brand new, Erica, to understanding CDI. No worries. We'll go over the details. Always curious to know if anybody else in the group might have an opinion. Catherine summarized it nicely in the chat box, but anyone that wants to explain it in greater detail? In the class, you'll have to speak up to be able to learn from me, because I won't know what you know and don't know uh, unless you share your thoughts. There's no penalty for being a little bit off base with what you're saying as long as you try. That's the most important piece to consider. Okay, Lisa's got a nice long answer here. Let's see. They already said the capture rate for CCs, MCCs was increased, and the only thing to change reimbursement is the complex pneumonia queries. Beautiful. Nicely said, Lisa. And for those that don't know, how are we going to change reimbursement such that the complex pneumonia bucket or DRG family is reflected? What will you be revising specifically? Gloria says community-acquired pneumonia, or CAP, only codes to unspecified versus a more specified pneumonia, such as gram-negative pneumonia. Very good. So community-acquired pneumonia is going to code to J18.9, pneumonia unspecified, whereas there's a more specific code than that for gram-negative pneumonia. I agree. So the coding is true. I'm still looking for that core concept that the principal diagnosis needs to be reassigned. The principal diagnosis needs to be reassigned to reflect the right DRG. So it's only when you make the correct assessment of a principal diagnosis that truly matches the clinical presentation that you'll be in the correct DRG. But you're basically all the way there through your answers. So good job as a group. So because of the correct statement made above by Lisa that they already said, the capture rate for CCs and MCCs was increased, yet they're still not making as much extra money as they hoped they would on pneumonia admissions. Really, you should be thinking PDX must be what you chase up next. It must be an issue with the principal diagnosis then. So you're going to eliminate choices A and C right away, right? Because, sorry, let me go and advance one slide here so we can just, again, I try to highlight the heart of the matter is CC, MCC capture is optimized. We're still not making as much impact on revenue as we would think for pneumonia discharges. And the leadership is trying to understand how we can still improve pneumonia reimbursement. What is to gain is to ensure then, we must ensure that the principal diagnosis for each and every pneumonia discharge is the correct principal diagnosis for that pneumonia discharge. Now, we're saying we're not making enough money on pneumonia, and it's not about making money, it's about appropriate reimbursement, to put it in proper speak. The appropriate reimbursement for the type of pneumonia patients being seen at that facility, it's not there. It's still falling short of expected reimbursement. Fine. Let's look at choice D. Analyze the number of stays for community-acquired pneumonia, CAP, documented as gram-negative pneumonia, but without the validating clinical evidence. So maybe you have a provider who just got tired of hearing from CDI every 5 minutes. Is it gram-negative? Some version of that in a query. So they just start writing gram-negative a little too more commonly than they should. Even when it's just community-acquired pneumonia, which is an unspecified code, goes to 193 to 195, a simple pneumonia DRG. So what's going to happen to reimbursement if choice D is the pervasive and problematic pattern? Will it go up or will it go down compared to expected? Yes, good, Catherine. Increase until it's denied, which it inevitably would be. So in the first instance, you would see a gain in money. That wouldn't be your problem in the first instance. You would see gain in reimbursement, not less reimbursement than expected. But B, we have the opposite. Analyze the number of stays for gram-negative pneumonia, documented as CAP. Right? So we had all the, when we look at the chart, we see all the right antibiotics are there, all the risk factors are there for gram-negative, but it's being documented just all the way through to discharge in that way. If you keep doing that, you're just in the wrong DRG family, and there's no amount of CC, MCC capture that's going to mitigate the full reimbursement piece. So we have a very important way to think about this from management perspective. Now, many of you on the call might say, this is peculiar to me because, I don't really understand the full implications of this. Some of this seems to be about metrics, program management. Yes, if you've been in the field for 2 years, which is a mandate to take the CCDS exam, then you would understand some of these points a little bit better. If you haven't been reviewing charts for 2 years and been privy to meetings about metrics and had your leadership walk you through some of the key points and conclusions you can make from those metrics and how it pertains to your work, then you wouldn't have the insight to answer a question like this one. So on a CCDS exam, you won't just be asked simple questions. Some of them are straightforward, but the ones that make or break whether you can pass or not are largely born out of your practical, vocational experience in the field, having seen real world problems. And there are questions that you should be able to answer on basic shifts in metrics. So I appreciate all the comments. We only have time for so much here. I wanted to just go through and share with you a little bit more about the overview of the 30 hours of the course. You can see that we have that diagnostic exam at the front end, so we know which multiple choice questions to give you. Everything in the class is question-based review, but you have the accompanying supporting materials to help guide you. So we go through a number of critiques of provider assessments and how they can be less than ideal. You can see across a whole host of different health conditions in the first 4 classes. In class 5, we talk about those production and query metrics that you may know and love from your 3M and other software reporters. It lets you know how many charts per hour you're reviewing and how many of your queries were financially impactful. And we're not going to go over the concept of it. We're going to go over the questions obviously related to it, and there'll be a leave behind document that you can utilize to help answer some of those questions as you practice them. Also, provider query reply metrics. It's important you understand what different types of provider query reply responses might mean about the CDI specialist, the provider, or both in that exchange. In class 6, we talk more about what we just talked about in the earlier CCs, MCCs, DRGs, CMI trends, risk adjustment, and so forth. I see a question popped up. Let me take a pause after class 6 here. Where can I inquire about the cost? It's just in a few slides from now. Bettina, thank you for the question. We will surely address that as well. So the applying of coding guidelines is the topic of the next 2 classes, making sure you really understand PCS and CM code guidelines and the way in which DRG assignment occurs. Something about MDCs as well for you to consider in some of the questions, and then the important topic of clinical validation, the centerpiece of being preventive with the approach to denials management. Class 9, PSIs, hacks, POA indicators. I'm sure most everyone on the call, if you've been in CDI for any period of time, understands that you must define present on admission indicators to be able to know if something is a patient safety indicator often, or if it's a hospital-acquired condition in any case. The cardiac and respiratory systems and the other systems that you saw before get revisited in some of the questions in weeks 10 through 12, where we describe the medical science and diagnostic knowledge that you need. There is a section for the exam that does a CCDS exam that tests your medical knowledge. And so that's something important also to consider. The class then looks at query compliance, making sure you're compliant with the 2022 latest practice updates from AHIMA on query compliance, and also safeguarding against audits through various practices. Those questions are designed to test those areas. PEPR reporting, value-based purchasing, round out the course along with expected mortality and denominator diagnoses for risk adjustment with the mortality index. And there's a final concepts checklist that we'll come to in the course and do a further inventory. At the end of the course, you have another test that's 100 questions in length as a final assessment to see how you feel about going ahead and taking the exam that you've scheduled. So those are the 30 hours of course work accounted for. For those of you that were curious about dates and costs, the next dates are the 27th of this month, as well as the 3rd and the 17th of next month for our course getting started. The cost of the course is $949. We do have payment plans available that can stretch that cost out over even a year or two if you prefer, through different pay systems, Klarna, Affirm. I think there's a couple of others on there as well. And some enrollees decide close to test time, I'm not going to take your course, but I'd rather still take your diagnostic test for this exam. That's available anytime. You can enroll in that anytime. It's 100 questions in length, and it includes a one-on-one live online meeting to go over all of your results from the diagnostic and give you a recommended course of remediation should you not really feel like you're that ready because of your outcome on the test. The cost of that is $199, and that is applied if you choose later on to take the review class. That is applied towards the cost of the class. So you'll be removing around $200 from the price of the course if you choose to do things in that way. The other upcoming event that we're very excited about is having been invited to AHIMA's Virtual Coding Summit for this year on February 7th, where I'll be speaking about acute tubular necrosis and a collaborative approach to clinical validation. You can register there. It is either at the AHIMA store or I think on the events tab. But on our website, we have the direct link for you to be able to go through and register if you'd like to attend that event. So very important event for the year. That's what I have to say. And before I pause for your questions, oh no, one more thing I did have to say, my apologies. We do have another webinar just like this one for an hour or so this coming Thursday, the 23rd. If your interest on this call is less on taking the CCDS exam and maybe learning more about the field and how to educate yourselves further to the work that CDI specialists do, we have on Thursday at 7, navigating your CDI journey, learning about the skills, the strategies, and the certifications needed to enter this field and to succeed in this field. So do feel free to register by sending us your email address. Just send us an email to info@cdiqconsulting.com and you can get a link for that meeting on Thursday sent back to you. So I think that was it for today. I want to back up because I think I saw a question. No, it wasn't about that. I can leave this up anyway if you'd like. The floor is open to your questions. First one from Edith, and I saw you wrote that early, so thank you for retyping it, and you saved me scrolling to the top. Is CCDS a higher ranking certification than CCDS? Oh, I wouldn't say so. I think the integrity of the ACDIS benchmarks to be credentialed there are similar. So I'm not sure I would even think of it as a rank, but they're both just as important certifications depending on the work you do. So if you want to work in outpatient CDI, it's the absolute relevant credential that you'd want to get to do that kind of work. I wouldn't say that it's higher or lower ranks. I don't see an analogy there between CCS and CCSP and the others like CPC and all that. Thank you for the question. How often is certification renewal, and what are the CEUs? It's every 2 years. I should know the number of CEUs because I have to do it every 2 years. I think it's 30 if I'm not mistaken. I could be wrong, but I usually try to make sure I have more than I need. It's every 2 years, and you want to start early on your CEU acquisition process so you don't get stuck at the last minute as your CCDS is expiring, scrambling to do many activities at once. Not that I would know anything to do with that, but like most humans, we get busy, and it's possible that you may have a bottleneck where you have to do a lot of last second CEU work to get yourself recertified. Also a very good question. How often is a prep offered? Bettina asks, good question. You see the 3 dates that are listed there are our next 3 scheduled class dates, meaning we have somebody in each of the classes already, and we have some space for more. But we actually have classes, we have availability to start classes weekly and even on odd days of the week. So we have custom times for different time zones, for different times of availability in the day. And those are not the only dates. You simply need to write to us to be able to understand what we can accommodate in terms of your schedule. Nicole writes, so thank you, Bettina. Nicole writes, how is the CCDS exam prep class done? Is it weekly or more like complete at your own pace? Another good question. We are soon considering making a self-paced version of the course available for those that like to self-study, and as well as a hybrid version of the course where it's not 100% delivered live, but just some teaching input along the way with a lot of self-study. But for now, the format that we offer is the 30 hours live uh, completely, and the two typical meetings that are meeting frequencies are Monday, Wednesday, Friday schedule, or Tuesday, Thursday, Saturday morning schedule. Just depends what works for you. We do offer time slots on a Saturday morning, so you're more than welcome to consider a Tuesday, Thursday, Saturday schedule if that's what works for you. Do you need to be an RN is the next question to be hired after you are. Yeah, so the issue with getting the CCDS and the RN status is it's a degree, it's a not a degree, but it's a certification that is designed for RNs, medical doctors who have done this work for 2 years. That's not to say that HIM professionals, clinically oriented allied healthcare professionals, retired physicians, there's a whole slew of different people that may endeavor to do CDI work. But regardless of what your credentials are, an RN is certainly probably the leading credential that we see for potential examinees. Regardless, you need 2 years in the industry. Um, you need to find a program that is willing to work with you because you've shown acumen at the interview points. Um, without the credentials and with the promise that you'll slowly earn them. Those jobs are harder to find than others, but it's not as though they're not out there. You just have to hunt for them. Your local hospitals where you live may have such positions. They may not be remote and they may not pay as much as you want in the first instance, but you're trying to go into a new profession. So I'm a little confused by the question because regardless, you'd have to have 2 years in, no matter what your degree is, and somebody would have hired you based on your degree. So uh, I'm not sure that the RN is a mandate, but it certainly helps. Let me see what else I see here. Back up a little bit. Benefits of being certified versus not outside of prestige. Yeah, again, the certification really lets the industry know that you are an more advanced practitioner of CDI, that you understand more than just the basics of chart review, that you understand deeper implications of your work. And so it's a standardization of sorts to let employers know exactly that which you need to know to do well. So your opportunity for hire becomes a lot into different types of CDI roles becomes much greater, and the broad, diverse nature of job opportunities increases as well. So it's not so much about prestige as it is a practical certification that helps you to do more in the industry, I would say. The wait time is 3 years for allied health to take the exam, is what I'm reading from Chantel. I'm not sure, Chantel, if you can send us a reference for that. I sure would appreciate it. Maybe it's in the latest guidelines in the examinee handbook and I've missed them somehow. But for sure, you're welcome to share with the group in the chat box if you can where you've got this useful information for us from. Other questions? It's on the ACDIS website. Thank you very much. And you're an RRT. Okay, well, there is a reason for all of the rules set forth by ACDIS for the wait periods. And it speaks to how long it's felt for you to get up to speed with the global skill set needed to be a certified CDI specialist, nobody wants to be set up to fail. So there's a good logic behind why you have to wait 2 years to take this exam. It's not that you're waiting for anything, you're acquiring the necessary acumen, the necessary knowledge base to take that test. If you try to take it too early, you may not pass the test, quite frankly. So that's something to consider. It's okay. When you work with us, we don't leave you at the finish line of the final 30th hour of course delivery. We work with you on understanding why you didn't pass if you still don't pass. And we support you for that following year afterwards to make sure you get what you need to stay on track. Good questions today. I appreciate this good attendance and also the number of questions that I'm seeing. I'm pausing for others. Anna, as you look through the chats there, did you see anything that I've yet to address?
I think that you've answered, pretty much kind of gone through and answered, kind of in real time. So we do appreciate, but feel free, anybody else that has any Q&A, either in the chat box or, unmute yourself and feel free to share. We would love to, have more questions and answer more.
You're very welcome, Erica. Thank you for attending, and sure nice to see you here. Feel free to attend our others. We'll have these monthly to help guide those who are interested. They won't always be as general as today's was. We'll pick focus topics to really help you understand how we dig in on certain specific subject matter.
I have a question in regards to the actual job prospects of getting a CDI position with a CCDS.
Mm.
How long does it take on the average to land a job? Because especially in CDI, because from at least the support groups that I have seen, it's kind of the job market is kind of a bit more challenging than I was informed back in like 2, 3 years ago, where it was more like hospitals were actively looking for people. But now it looks like the like everything is changed, even the recruitment process. So I just want to know, like, what's the my chances of likelihood of literally working in CDI with a CCDS?
Fair enough. Yeah, good question. There have been some changes over the years, and interestingly, these are cyclic changes of sorts. For example, the composition of a CDI program in terms of staffing. Um, in some areas and in some seasons of how it works, you see a lot of MDs and RNs working side by side in the um, in the workspace. Others, some years come along, it seems like medical doctors are not favored in the job descriptions, and the jobs almost become exclusively available for RNs only with a license in the state for the hospital where they want to work. So there is that to consider in the variability. As far as the average, the beginning of your question was, what is the average length of time that it takes? I don't have a good number for an average because each candidate that I work with has usually a different background. They don't all have the same uniform background, so I wouldn't be able to give you a fair comparison. Those who have HIM only backgrounds are not going to um, have as easy of a time as those who have a clinical background, shall we say. No, Nicholas, we'll review more questions in next month's session. It'll be a more question heavy session. So if we're waiting for more questions, we don't have any more for tonight. But Edith, back to your question. It's a good one. That's a question better suited, I think, though, for should I endeavor to take a CDI training course or an apprenticeship or a boot camp or something like that, where you're thinking about the job market. Remember, again, this exam is for already employed CDI specialists with at least 2 years in the field. And so that it doesn't come up for me with this cohort of individuals that I work with. These individuals are already in the industry, so whether they're employed or not is not even an issue. For the comprehensive CDI apprenticeship program, we do have some data on that, but again, it's not average data. We have it broken out by subsection of individual. Is it live online class? It's a live online class, Faisal, that is delivered and it's recorded. So After you finish the 2-hour class, you can go back into the learning platform and you can pull up the 2-hour recording up to a year after it was delivered. And you're able to revisit the concepts within the classes. These are all great questions that you're asking. Thank you so much, Michelle. Appreciate your comment. We'll look forward to seeing you there as well on Thursday then. That's great that you're coming to that session as well. Faisal, the payment plan works by going onto our website and purchasing any of the courses, any of them that you'd like to purchase. You simply click to go to the payment link, and at that point you will see options beyond entering a credit card number. You'll see options to enroll in one of the payment programs there. So they're already built in with all the other ways of paying. One interface will give you all the payment methods. Thank you. Thank you both so much. All right, we're wrapping up on time here, folks. If that's the end of the questions, again, very grateful to you all. Feel free to write to us, info@CDI Consulting, CDIQconsulting.com. Yeah, there you go. Thank you, Anna. Put that in the chat box for the website. But again, thank you all. Hope to see some of you on Thursday and hope to see some of you in the exam prep class if you think what we offer might work well for you. Okay, everybody, have a great rest of your night and see you soon. Take care.
Thank you, everybody. We really appreciate your time and your effort, and we are here to answer any questions. Be safe, stay warm.
Bye-bye.